PowerPoint will be available on the ASAM Transition website after the meeting today. And if you have suggestions for future topics, and we don't have a topic slated for the June call, so if you have anything that you would like us to speak about as it relates to the ASAM transition, please don't hesitate to drop those suggestions in the chat box, or you can email those to us, again, at the email address noted here. So just wanted to, and we always kind of give this disclaimer. So ASAM alignment is a requirement of drug and alcohol treatment providers that receive funding for providing treatment services under agreements with single county authorities and managed care organizations. So it is a requirement. And I just want to remind people that the information presented here today is just a snapshot and really does not replace the importance of reading the entire ASAM text, attending all the trainings that are available, looking at the various resources that we've developed on the DDAP website. And also just want to, remind people that the ASAM 2-day training is required for all case managers, their supervisors, and all SCA contracted treatment provider staff and their supervisors. So always want to give that disclaimer. And I'm really excited this morning to turn it over to Tim Rader early on in the presentation. Before we get into the topic of support systems, we're going to be talking a little bit about everything that's been going on with training over the past couple months, past couple years as it relates to the ASAM transition. So I'm going to turn it over to Tim to go next.
Hi, everybody. Thanks, Kathleen. My name is Tim Rader. I work in the training section at DDAP. And again, Kathleen, thanks for the opportunity to discuss training, especially courses supporting evidence-based care. It's been a big component of the ASAM transition. So to start, and for those unaware, DDAP, I'll start with foundational ASAM training. And DDAP has approved 3 separate options to complete foundational ASAM training. First, an interactive and self-paced online course from the American Society of Addiction Medicine, an online course from the Change Companies, and an in-person instructor-led course from Train for Change. Any one of these options will satisfy the requirement for foundational learning for the ASAM criteria. And if in each of them, look at the foundation, the theoretical foundations of and guiding principles of the criteria, multidimensional assessment, treatment, and service planning that stems from those assessments. And if anyone's taken any of these courses, they're well designed, filled with practice assessments. They're very interactive in their learning activities and filled with knowledge checks as well. And since 2017, when we just started transitioning, we're aware of well over 13,000 certificates issued in PA across all of these products. You can find, as Kathleen mentioned, you can find full descriptions and access instructions on our ASAM transition page, but I'll also drop links to them in the chat as well afterwards. Next slide, Kathleen, please. Excellent. So we also have several complementary trainings that support both ASAM alignment and the department's commitment to evidence-based practices. These courses can be found in our DDAP training management system. I'll send that link as well if you're unfamiliar with that system. And I'll run through each of these. I'll briefly describe each, and then afterwards, like the ASAM trainings, I'll follow up with some more detail on how you can access them. So to start, we have the treatment planning with ASAM criteria, and it's been very popular since we launched in August. It's 6 hours, and as the name suggests, it really provides attendees with a blueprint to treatment planning that's collaborative, person-centered, and rooted in a multidimensional assessment. Next is our 6-hour co-occurring conditions course, and that's also relatively new with just about 90 students trained to date. However, we have many more on the schedule. And fundamentally, this course acknowledges that comorbidities are common, if not the rule, rather than the exception, and that programs need to design services that address them. So students in this course learn current principles and terminology, screening, assessment of COD, and really what integrated treatment and integrated treatment planning looks like. Next up, our course in CBT. We call it Cognitive Behavioral Strategies for Treating Individuals with Substance Use Disorder. And this is a 4-part curriculum. It's incredibly comprehensive, starting with an online module, which lays the foundation to start building skills in phase 2. And then in phase 3, they demonstrate and evaluate skills based on real client assessments. And then the final phase really focuses on fidelity to the model. So to date, we have trained, I believe, over 150, and with many more having taken the first part, phase 1, the module, and are planning to go through all the other phases. But in total, over 150 have completed the entire curriculum. And then last but not least is our course in motivational interviewing. This is 2 days if taken in the classroom and 5 3-hour sessions if taken virtually. The course was developed in collaboration with MINT trainers, and that stands for Motivational Interviewing Network of Trainers, and they're international in scope. And as well, we collaborated with trainers of the ASAM criteria as well. So really the focus of this course, is to build skills needed to engage clients in a recovery process, but also, and right now, more importantly, for attendees to leave with a clear understanding of how MI relates to applying ASAM criteria principles in ongoing client assessments. And I also want to make you aware of an optional and advanced part 2 of this course if you're not already aware of it. So after the 2-day course, select participants of the 2-day course or the 5-session virtual course have an option to attend 8 monthly learning collaborative sessions. So each of these sessions is around 3.5 hours and intended for those in a position to affect policy and procedural change within their program. So clinical directors, quality improvement directors, program managers, clinical supervisors, they use the time in these learning collaboratives to use the time with coaching to develop strategic quality improvement plans for their agency. So, and they're able to choose any area of focus, but most, especially now, seek to infuse MI into the daily practice of their programs because of its critical connection to applying the ASAM criterion. So all of this really was designed and done using proven models of quality improvement, first to set measurable goals that are attainable, and then a plan to achieve those goals gradually over time. So the premise being that improvement isn't usually accomplished by one big change. It's a series of smaller changes, each honored, each tested and implemented one at a time that, eventually adds up to a big impact. So that wraps up the training portion here. I know I said a lot there in a short amount of time, so that's why I want to follow up and I'll drop more information in the chat, including a link to our training management system if you're not familiar with that. I'll also add our contact information directly to the training section. If you're having trouble accessing any of these courses, I want you to please call us. We'll be happy to assist you in finding a seat to any of those courses. Kathleen, that wraps it up for me. I appreciate the time. Thank you.
Thank you so much, Tim. And I forgot to introduce Tim. How could I have done that? So Tim is our chief of the training division at DDAP, and him and his team have been such an integral part in the ASAM transition, training so many people over the past several years and continuing to offer really important evidence-based trainings. And there's some really exciting things kind of coming down the pipeline. Won't tell you exactly what those are yet, but there will be some really exciting things coming in the next couple of months and years as it relates to evidence-based training. So thank you so much, Tim, to you and your team.
My pleasure.
All right, so now we're going to get into kind of the learning objectives for today. My hope is that you are going to leave this training today with a better understanding of just support systems that are required at each level of care. And you'll understand kind of exactly what support systems are. We're going to be looking at the definition of support systems on the next slide here. And as the presentation goes on, I'm going to be using 2 different levels of care. So one for outpatient, so 2.5, and one for residential, 3.5, to provide some examples of what it might look like to implement these support systems with the understanding that I am only providing examples. These are not mandates. There's no one right way to kind of make sure these support systems are in place, but I'm just going to give you all some food for thought. And a lot of you may already be doing these things. And then as we're exploring these support systems today, you might be thinking about your own programs and potential barriers or issues that might make it difficult to ensure these support systems are in place. This is okay. And I really I want to make sure people know that, we've worked with many providers, particularly around level 2.5, in navigating some of these barriers and brainstorming ways to ensure the necessary support systems are in place. So if you're not quite sure how this is going to look or how you're going to do this, ask for help. Please reach out to the ASAM RA email account and ask to set up a call with us so that we can do some technical assistance and we can help you navigate these barriers. There are many providers that we've had multiple calls with to kind of work through some of these barriers that they might be facing to make sure that these support systems are in place. All right, so those of you who have been on these calls before, I think you know that I really like the definitions that are in the back of the textbook. They're a great resource. But when we look at the definition of support systems on page 431, we can see that these are services that do not have to be embedded in the program. So you do not need to hire extra staff to do these things or build additional wings or additional departments. Rather, these are relationships and these are agreements that simply must be established and they must be in place so that patients in that level of care can easily and quickly access these really important additional services. So programs may have agreements in place so that transportation is arranged for the patient to help them get from one SUD program to a psychiatric evaluation or a medical consultation. They may have someone come on site a couple days a week to draw blood or to collect urine drug tests or to conduct psychiatric evaluations. There are just many, many ways to set up these support systems. It's just critical that they're set up and that there's ongoing coordination and communication amongst the various players in these systems. So please take a moment to look at the definition of support systems in the back of the text at some point. All right, so like many other things related to ASAM, there's going to be quite a few common themes that we're going to touch on today. And so as we're looking at each level of care and the support systems required, you will begin to see some of these common themes. We'll see that each level of care is expected to have relationships with other levels of care, reinforcing this very central component of ASAM, of the continuum of care, which is an integrated network of treatment services and non-clinical modalities designed to meet the changing needs of individuals as they progress through treatment. So movement from one level of care to the next should be seamless. It should be congruent with the treatment philosophy, and it should be a rapid clinical transfer. So there should be nothing that holds up this transfer, like transfer of the clinical information, of the clinical documentation. It should be as non-disruptive to the patient as possible. Again, we all know this takes a lot of coordination and planning between providers, but once these relationships are in place and the process is ironed out, it should work very efficiently for all involved. The rest of these common themes, and these aren't all the common themes that we're going to say, but these are some of the really big ones that we see throughout each of the levels of care. So the rest of these common themes really speak to kind of dimensions 1, 2, and 3, and making sure that programs have relationships in place to ensure that psychiatric and medical conditions are being treated, withdrawal symptoms are being treated, relevant testing services are available to make sure to make appropriate diagnoses so that the individual can be connected to other services they might need while they're in treatment or after they transition to a different level of care. And so as we go through this presentation today, I want to encourage you to identify other common themes that you may see and to also be looking at specific levels of care, not just as this one kind of level of care and that's it. So we want to be making sure that when we're looking at these support systems for this level of care, that we're thinking about the other levels of care that are part of this larger system. So just want to make sure that people are kind of keeping that in mind. And I also want to encourage you to recognize that there's a significant overlap in many of the licensing regulations and what we're going to be discussing here today, particularly in the 709 regulations. So they really speak to things like medication control, making sure that projects obtain necessary support services for patients, making sure that there's our policies and procedures in place for emergency situations that may come up, making sure there's policies and procedures in place for transfer and for discharge and for aftercare and for making sure that the patient is followed up with when they transfer to a different level of care. So there is quite a bit of overlap with a lot of these licensing regulations. So the reality is that providers are probably doing a lot of the things that we're going to be talking about today. And then finally, I want to encourage you all to kind of think about how case management fits into this theme of support systems today. We all know that case management is an already existing, incredibly important resource. So just kind of be asking yourself, what role can case managers play in implementing these support systems and being that steady kind of presence as a patient moves along the continuum of care? All right, so along this idea of common themes, as we're about to kind of look more closely at the support systems by level of care, we can see that, you know, when you're reading the ASAM text and each level of care has the support system sections, every single one of these support system sections discusses access to medical and psychiatry, and it talks about a specific time frame. And so as we see, as the level of care increases, we see that time to access medical and psychiatric services decreases. So in other words, the more intense the level of care is, the more quickly the program must ensure that the patient is seen by medical and psychiatry. Also related to this slide, we know that with COVID, telehealth has become an increasingly available option for many providers and has helped in so many ways. So just to be thinking about that as we're looking at this slide. And those of you who have kind of gone through the formal alignment process with DDAP for either 2.5 or 3.7 are very familiar with us asking for evidence or proof that medical and psychiatric consultation is occurring with the noted timeframes here. And I just wanted to point out here, so I do have an asterisk, or I have a couple different asterisks, but right here by medical to talk about the fact that and ASAM makes this very clear that in states where it's allowed, nurse practitioners or physician assistants may perform the duties of a physician as a physician extender. So it just varies state by state. And then for level 1 within 24 hours by phone, put a double asterisk there, and you can see this in the ASAM text. But really it's within 24 hours by phone or really as needed based on the individual situation. So just to be making sure that you're looking at the text, making sure that you're noting the timeframes, making sure you're understanding that as the level of care increases, we're going to need to make sure the patient is able to see medical and psychiatry much more quickly. All right, and I'm just going to take a look at the chat here to see what I have going on. Okay. So now we're going to start to go into the specific levels of care and talk a little bit about the support systems in each level of care. And if you have your ASAM textbook, you could pull it out and you could actually follow along with me as we're going through this. But I'm including the page numbers here today so that you all know exactly where to find this information in the ASAM textbook. So with level 1, I want to touch on the emergency services part for a minute here. In ASAM, all outpatient levels of care state that emergency services must be available 24 hours a day, 7 days a week. So this is possible, a variety of ways. It could be a crisis hotline. It could be an on-call staff member. If the program is affiliated with a hospital, it could be setting up something with the admission staff who are skilled at treating emergency and crisis. Maybe the program has an agreement with an SCA to handle 24/7 emergencies. Again, there's a lot of different ways to make sure this happens. It just, something has to be in place. And not only does something have to be in place, but the staff need to know this plan very well and patients need to know this plan very well. It needs to be explained to them very clearly so that they can actually utilize these emergency services should that need arise. So, and I forgot to mention this in the beginning today, I'm going to ask for a little bit of participation today. And so I didn't mention that in the beginning, so apologies about that. But if you're willing to kind of participate today or to offer any examples, what I'm just going to ask you to do is to raise your hand. And then I will unmute you if you're willing to share. So we'll see if people are comfortable doing that today or not. But this is going to be the first part where I'm going to ask people to share. So I'm just curious, Are there any outpatient providers on the call, so it can be not just level 1, but 2.1 or 2.5, willing to share how they handle emergency services and how do you ensure that these emergency services are available by telephone 24 hours a day, 7 days a week? Just wondering if there's any creative kind of agreements that people have out there or systems in place anybody is willing to share about. So gonna just stop here and see if anybody wants to raise their hand, and I will unmute you if you're willing to do that. I see a hand. All right, I think, Jennifer, is this you? You should be able to unmute yourself, Jennifer. I'm going to try one more time here. All right, Jennifer, you should be able to unmute yourself if you want to.
Hello?
Yes, hi.
Hi. Sorry, it's a different screen that I'm used to. I couldn't find the button.
No problem.
We have kind of letters of agreement with 7 like site services.
Jennifer, would you mind just restating that again? You're cutting in and out a little bit. Just maybe if you could just start over, that would be great.
All right, we have agreements, like letters of agreements with the hospitals that provide 24/7 site services. And then we use the 800 numbers. And we give everybody a list of all.
Okay. Great, Jennifer. So for those of you who had a hard time hearing, first of all, Jennifer, thank you for sharing, but it sounds like you all have an agreement with a psychiatric hospital, and you have an agreement with another hospital as well. And it sounds like you hand something out to patients so that they kind of know very clearly what that process is.
Correct. Okay.
Yeah, perfect. Thank you so much. I appreciate you raising your hand and participating. Does anybody else want to share? No? Okay. All right, we're going to move on to level 2 now. So we're going to be talking about IOP. So we can see here that there are many similarities in support services. And it's important to note that some of these support services may fall under the therapies that qualify towards that 9 to 19 hours of skilled treatment services. So I'm specifically looking at this first bullet here and the medication management, which absolutely counts towards those 9 to 19 hours of skilled treatment services that are required at this level of care. So sessions and time spent with the psychiatrist and the psychologist would also count. Also to note here that a defining characteristic of the IOP support systems is coordination with supportive housing, which we don't see in level 1. So a lot of level 1 programs, a lot of you on this call here today may have that set up with your level 1 program, coordination with housing services, but it's not noted in the ASAM as a requirement. So I'm gonna just stop here again and ask for participation and see if there's any 2.1 programs or even 2.5 programs, because this is also a common theme in 2.5, who have relationships with providers who provide supportive housing services and kind of what that looks like in your program. So just if anybody's willing to kind of raise their hand and share, again, the question is, are you a level 2.1 or a 2.5 provider that has relationships with entities that provide supportive housing services, and what do those look like? So I'm going to just take a second here. Again, if you want to participate, you can just raise your hand and I will call on you. Also, if you're more comfortable and if you are a 2.1 or a 2.5 program that you have relationships with providers who offer supportive housing services, you can also just type that in the chat. Just curious to know how many of you have this already set up and in place. these relationships to supportive housing services. So just give it one more minute here. Great, Amber, thank you for typing in the chat. So Amber says we have a housing program within our agency as well as using the SCA intensive case management program for housing funds. Fantastic. Thank you, Amber. Amber, can you, I'm sorry, I should probably know this. What SCA are you with? Would you mind typing that in the chat? Or which agency are you with? I'm sorry. All right, we're going to move on here. Going on to, so thank you, Amber. She's with UPMC Western Behavioral Health in Blair County. Perfect, Amber, thank you. So this is what I was talking about in the beginning of the call. So I have examples for outpatient and for residential about what this could look like. What would it look like to make sure that these various support systems are in place for level 2.1 specifically? So again, want to make sure, and I kind of bolded and underlined, what could this look like? So this is not a mandate. This is not what it has to look like. This is simply just an example for you all. Hopefully it's helpful to you. So this is maybe some of the things that could be in place to make sure that these support systems are available. So on the left, in terms of development of policies and procedures or implementing written agreements. So this is something that could be helpful to you, and I want to make sure that you understand that that we actually have a lot of these already available. These examples of policies and procedures and examples of written agreements that would have to be laid out for specific levels of care on the DDAP ASAM transition website. And those are in specific documents by level of care. I'm going to show you that at the end of the call today. So these are actually already in place for you as a very, very helpful resource. You can use these as a checklist, and we go through these not only for support systems, but we do that for staffing and therapies and documentation by each level of care as well. So you could see exactly what this looks like. And again, this is not a requirement. This is not a DDAP mandate. These are really just examples to help you all as you're thinking about how are we going to make sure this is in place for our level of care? How are we going to make sure these support systems are in place? What is this going to look like from a policy and procedure level? What is this going to look like from a written agreement or an MOU level? All right, moving on to 2.5, our partial hospitalization programs, and understanding that this level of care is a level of care designed for patients who have significant issues in dimensions 1, 2, and 3, and who really most of the time require daily monitoring in these dimensions specifically. So again, it's not that they don't have issues in 3, 4, and 5, and 6, or I'm sorry, 4, 5, and 6. It's that the significant issues, the more significant issues are in dimensions 1, 2, and 3. So these programs typically have direct access to psychiatry, to medical, and to lab services. As we all know, this is a level of care that requires 20 or more hours a week of skilled treatment services. And some of these support services may also be included in those list of therapies that would count towards that 20-hour-a-week daily, or that 20-hour-a-week skilled treatment services requirement. So kind of just like IOP, I'm thinking specifically about those medication management services. I'm thinking about those psychological services. You will also see here that there is the continued focus on supportive housing as there was in 2.1. And and again, obviously the emergency services are in place as they are for all levels of care. Going to 3.1, so this is in Pennsylvania, most likely a halfway house. This requires at least 5 hours a week of skilled treatment services, allied health staff, so techs usually are on site 24 hours a day. Generally speaking, this is a level of care that is not for individuals who have significant issues in dimensions 1, 2, and 3. Rather, it's really for individuals who are very much in need of assistance in developing recovery skills, self-efficacy, they may have a lack of connection to community and to work, to school and to family life. They need help practicing interpersonal and group living skills, strengthening recovery skills, reintegrating back into the community and family. That's a really big focus of this level of care. So individuals at this level of care might need more intensive, they could need more intensive treatment, and that could be provided through a relationship that the 3.1 has with an IOP or with a PHP while they're in this level of care. So making sure that this level of care also offers access to psychiatry, quick access to psychiatry or medical care, regular checkups for MAT, connections to several resources to promote employment, education, and development of general life skills, really key for this level of care. Again, just going to encourage you to stop and think about what role could case management play, particularly in this level of care, and really at all the levels of care that we're talking about, but think about it as it relates to this level of care specifically. All right, going on to 3.5, and this is the other example that I'm going to use in which I lay out very specific ways that the policies and procedures could be laid out and that the MOUs could be laid out to make sure that all these support systems are going into practice. So 3.5 programs are for individuals who have substance use disorder that is really so out of control that they need a 24-hour supportive treatment environment with daily clinical services. So significant issues are in dimensions 4, 5, and 6. Common issues could be impulsivity. It could be a history of many treatment episodes. It could be a history of significant return to use after treatment episodes, criminal history. It could be poor coping skills. So those are the kind of things that we're thinking about for individuals at this level of care. Physicians must always be available for consultation. And once stabilized, patients should be moving along this continuum of care. So if symptoms increase while they're at this level of care, then we're thinking about a transfer to a higher level of care that would be warranted. Ongoing addressing of medical and psychiatric issues are available as needed based on each individual patient situation. So it's really assumed at this level of care that providers are going to require assistance to meet many of these support system needs. So again, this assistance can come in a variety of ways, and we'll look at that in more detail in a minute here. But generally speaking, this occurs through affiliations or agreements. There must be access for both parties to have a steady flow of communication if you do have agreements set up. So making sure that that psychiatrist that you have an agreement with is able to kind of really quickly communicate back to you confidentially. And there's a steady flow of communication back and forth. Making sure that you know of recommendations that are coming up with all the support systems that are providing services, so that this information really has to be a steady back and forth flow. And this is really critical to make sure that the patient is successful in transitioning to a more autonomous, recovery-oriented way of living. All right, and I'm going to go into kind of the examples we have here for 3.5. So again, it's not a mandate. This is not exactly what it has to look like, but these are really just examples for you all. And I'm just going to leave this up here for a minute so that you can take a look at what these policies and procedures might look like or what they might detail and what kind of written agreements would be in place for you all. While you're looking at that, I'm just going to take a look at the chat here. Thanks to everybody who put in the chat information about how you're making sure emergency services are available and how you're offering housing supports. This is really good stuff. Thank you. All right, so I'm going to move on here. Level 3.7. So this is a level of care for individuals who have substantial issues in dimensions 1, 2, and/or 3. So this is essentially a level 3.5 with the addition of intensive medical and nursing as a component. A 3.7 program has to be able to provide daily medical and psychiatric monitoring, not only by nurses, but by physicians as well. Psychiatric care has to be very accessible, has to be accessible quickly because folks at this level of care commonly have significant medical issues, psychiatric issues. The program must have a coordinated system of agreements and relationships to ensure that specialty medical care is available, lab and toxicology services are available. When not available on site, these needs need to be met through affiliation or agreement. So also just a reminder to take a look at 3.7 as one important part of a larger network of providers offering multiple levels of care. So thinking about the close coordination that would occur between a 3.7 and a 3.5 or a 3.7 and a 4. You know, at this level of care specifically, we all know that patients can destabilize rather quickly. And so making sure that the systems are in place to make sure that they are safe if they need intensified medical or psychiatric care. And also making sure that as soon as patients are stabilizing in 3.7, that they can kind of shift down then to a lower level of care and making sure that that shift happens pretty seamlessly. And then finally, level 4. So this is offered in an acute care hospital, and patients at this level of care have significant or very severe issues in dimensions 1, 2, and 3. They require primary medical and nursing care, treatments provided 24 hours a day in a permanent facility with inpatient beds. The full resources of an acute care general hospital are available. So although treatment is specific to substance use disorders and other addictive disorders, the skills of the interdisciplinary team and the availability of the support service, including medical consultation services, allow the joint treatment of any co-occurring biomedical conditions and mental or cognitive issues that may be coming up. So again, in this level of care specifically, most of everything that you're going to need is usually available on site because this is an acute care hospital. But in the event that, let's say, for instance, that there's some kind of a specialty medical service that needs to be consulted with, then those agreements would be in place so that the patient would have access to those services so they can get that care while they're getting treated in this level 4 program. All right, so that is it for the various levels of care. I know we went through that pretty quickly. I'm going to show you, so right in front of you right now, I just want to give us a shout out again and just remind folks that we have the resources that we have available on the ASAM transition website right now are extremely helpful as you're thinking about, all right, how is this going to need to look on the ground? How is this going to need to look on a day-to-day basis in our program? So on our ASAM transition website, and I think most people know about this, but I just wanted to remind you all. So we have each level of care, and there's a drop-down menu for each level of care. So I have an example here. You can see level 3, and we have a drop-down that then shows 3.1, and it shows 3.5 and 3.7. And for each level of care, there are service characteristics, and then there's a self-assessment. So the self-assessment is going to be what you're going to use when looking at, all right, how would this potentially look? How would this look as employed by our program? And again, these aren't just focusing on the support systems that we talked about today. These are also focusing on staffing. It's focusing on therapies. It's focusing on documentation. So every single piece of what this would look like for levels of care is going to be noted in these self-assessment checklists. So please take time to kind of, look at those as a staff. You can print those out. Those are really, really helpful resources available to you on our website. So I have an arrow there to the one that you would look at. It's the self-assessment checklist. And I believe that is it. So I am going to go ahead. There's a little bit of time here. It's 10:42. I'm going to take a chance here and I'm going to answer some questions the best that I can. So I am going to, if you would like to raise your hand, we'll go through some of the questions in the chat that we can answer right now. But if there are people who have questions on the call and you want to raise your hand, please feel free to do that. And we'll do our best to keep track of who is raising their hands first. While we're waiting for that, I'm going to answer Gregory McDonald's question. Is there a chart like this for 3.1? Yes, there is. So there is a chart like this for every single level of care. And that's going to be under that self-assessment checklist that I just talked about on our ASAM transition website. So Gregory, I hope that is something that you can access and that you find helpful. And let's see what else we have here. Yes, I see somebody with a hand raised. So Gregory is raising his hand again. So Gregory, I'm going to try to unmute you here. Gregory, you should be able to unmute yourself now. You might just want to try one more time, Gregory. Just try to unmute yourself there.
Is it working now?
It is, yes. Hi.
Okay. All right. Hello. Thank you. Thank you for answering that question in the chat. I appreciate that. I'm Greg McConnell. I'm with 3.1 Men's Halfway House in Blair County, Phoenix Domus LLC. I'm one of the owners and the program manager. And this is the piece, and I'm so glad you're going over this today, because this is the piece I've been struggling with the most, because we have limitations in terms of physician availability, being able to get our residents in to get a physical quickly. If they don't come from, the facility that they're sending them doesn't send a physical with them within, our allotted time frame. So we're struggling with some of that. We have our policies in place for emergency care, and we have psychologists coming in and doing the psych evals, and we're contracted with them to do that within the first 30 days. So we got a lot of these things in place. We work closely with our local SCA and their case management group, as well as other providers and their CRS and case management, and they're really helpful in all these pieces. I'm just really struggling with the physician piece, and wondering if anyone else has that problem, especially with being able to get, if they're coming without a physical is one, but even more pressing is the issue that they're coming without a 30-day supply of medication. They may come to us with only a few days of medication, and we're scrambling to get them somewhere to get some medication. We thought about contracting with like a nurse practitioner or a physician or physician's assistant, but I'm just not sure what direction to go in there. Wonder if anybody has any advice or.
Yeah, Gregory, thank you so much for speaking up. So what I'm going to do is if anybody has any feedback or they want to speak to this this topic specifically, Jennifer, would you mind unmuting yourself and just kind of speaking up here?
Hello?
Yep, we can hear you.
Well, we're at 2.5. But we contract with providers 3 times a week. I'm sorry, 3 times a month.
All right, Jennifer, so having a hard time hearing you again, but I think what you said is that you contract with a CRNP and they come on site 3 times a month. Is that correct?
That's correct.
Okay, perfect. Thank you. Appreciate that. Anybody else want to share?
Kathleen.
Yeah.
It's Jody.
Yeah.
Hi. This is probably one of the most important pieces of case management as well. Case managers can help to coordinate that for you. Also, the treatment provider, something that you may want to do is require that they submit the physical upfront, like when they're interviewing, ask that they send the physical with the interview for the halfway house. That may help a little bit, but case managers, if you're working with them with the SCA or with the BIMCO, can help to gather that paperwork for you and help to get medications for you. That's what they do. So
Okay. Thank you so much for that.
Yep.
I appreciate that very much.
Thanks, Jody. Hey, Jody, since I have you on right now too, would you mind just taking a second to speak to the use of telehealth as it relates to DNA services? I know we can't speak specifically to the psychiatric component, but can you just take a moment on that?
yes, telehealth is completely okay with licensing. We are utilizing, it's a legitimate service. We are allowing it with our licensed treatment providers. We want to, we found that retention, especially with parents, with women, with children, this has been a lifesaver for a lot of people. So treatment providers that are able to offer both in-person and telehealth, we've been allowing that, as long as you have been able to provide confidential services. We do not, in a residential treatment program, you cannot use in telehealth as your primary source of counseling. Remember that you have a staffing requirement to meet. So if you're in an inpatient treatment program, there are staffing ratios that you must meet. So we've had some providers that have, and this is multiple providers, not just one or two, multiple providers that have tried to use telehealth as their primary source of counseling. And that can't happen in a residential treatment program. You need to have staff on site to meet those staffing ratios. If individuals were okay to be alone, they wouldn't need that 24-hour care. So telehealth is considered on an outpatient basis a perfectly acceptable treatment service, as long as the individual you find that they can handle that, they're clinically appropriate for that. But there are people that do need in-person services. So as a clinician, if you find that someone needs the in-person services, you really need to offer the combination of both.
Thanks, Jody. Jody, one follow-up question.
Sure.
There have been some questions in the chat about, does a video visit count as an in-person visit?
It does, as long as the individual is clinically appropriate for that.
Thank you so much.
Yes. So
very helpful. Oh, go ahead.
I was just going to say, as long as that in-person visit is that person is clinically appropriate for that. So some people need that true in-person visit. That real in-person, not the virtual.
Jody, I lied. I do have one other follow-up question.
I knew you would. That's why I had to say
that. So does the video visit count as an in-person visit for like a medical exam? I know for narcotic treatment programs right now, I believe it does. Does it? Is that correct?
It is currently still waived through the end of June. Yes, but that is only until the end of June. We are still working with the Department of State and with our federal partners to continue that.
Thank you so much. So Amy, I know that you just asked, will telehealth continue as COVID numbers continue to drop? We don't have a for sure answer on that. As Jody mentioned, we're working with our federal partners and we're working internally on that, but we don't have a response as of right now. All right, let's see what else we have here. Oh, I see some other hands up. So let's see. Judy, you should be able to unmute yourself now.
Okay, thank you.
Hi.
I just wanted to follow back up on Jody's comment on ICM, case management services from the SCA. That typically for a halfway house really wouldn't be able to meet the standard of the ASAM, which is what? They have to have something within 24 hours for 3.1. Is that correct for physical health?
Yep. So, oh, Jody, do you want to go ahead? I'm sorry. So Judy, oh, I'm sorry. Go ahead, Jody.
I didn't say ICM, Judy. I just said case management.
Well, that is case management. It typically would come into our system, which is a continuum of case management. But Yeah, we would not be able to support that as the SCA. That usually takes quite a bit of time to get a doctor's appointment, or even psychiatric especially. So I would be recommending to the halfway house exactly what you said, Jody, is they need to make that as part of their submission of their paperwork to consider that applicant to their halfway house, that physical history, and especially if they've had a psychiatric evaluation recently, that all be part of their packet of accepting that individual into the service when they apply. Because we would struggle also, the person wouldn't even be open in our case management.
Mm-hmm. And the BIMCOs have case managers as well, right? So,
well, no, not really. They have ones that are over the phone. They have care coordination too, but even still, I mean, we're at 8 weeks to get a psychiatric appointment,
mm-hmm.
and you may not be able to find somebody who will even accept a Medicaid individual in a physical health. So you have to have your own relationships, like the halfway house has set up, where they're
mm-hmm.
trying to support that through having their own letters of agreements and paying folks to be available to them.
Gotcha. So you're in case management?
Pardon me?
No, I'm just saying case management is still important, right?
Oh, it's absolutely important. And typically case management, even with the halfway house, most of these folks are Medicaid, and we can't even engage with them until 30 days prior to discharge. We can't even bill for them until that point. So they can't even be open in the more community-based case management services until that point, according to Medicaid rules. And most of these folks are Medicaid eligible. There's a lot of things that, that really does hinder the coordination of care through the SCA system, because most of these are Medicaid.
Judy, did you have a question about the time in which somebody needs to have a history and physical when admitting to a 3.1?
Yeah, I think it was like within the 24 hours or something like that.
Yeah, so on 226 of the ASAM text, it says a physical examination performed within a reasonable time as defined in the program's policies and procedure manual and as determined by the patient's medical condition. That's what the ASAM said.
It's general. Okay, thank you.
Yeah, you're welcome. Thank you for raising your hand. And we have a couple minutes here. I think I have everybody who had raised their hand. All right, so thank you everybody for participating today. I just want to say thank you. It was a really nice conversation. Thank you for everybody who put something in the chat, who was willing to unmute yourselves. Again, I want to remind you all about this resource that I have up here on the ASAM transition webpage. And as a couple of reminders, we have not solidified the topic for early June yet. So if you have any suggestions, please put those in the chat, or please send those to the ASAM RA email account. And please be sure to look at the ASAM transition page. I think everybody on the call knows this, but we've had some updates over the past couple of months, and there are some very helpful resources that are on that webpage, along with updates, just announcements, things like that. Please reach out if you need any technical assistance. So if this call today brought up any kind of concerns, any barriers that you think are going to make it difficult to make sure these support systems are in place, please reach out to us. We're happy to troubleshoot with you. And so we just please reach out to us, and you can do that by reaching out to the ASAM email address that's right on there. So thank you everybody who participated today. With that, we're going to close it up, and I'm going to leave the call on for about 3 minutes here in case anybody has any questions they want to type in the chat. Have a great week.